This is a case of 25 years old man with frequent bouts of severe hypoglycemia reaching as low as 30 milligram per dl, sometimes accompanied by convulsions and disturbed level of consciousness and improved by intravenous concentrated glucose. The level of insulin and C-peptide is high during the attacks of hypoglycemia. So the diagnosis of insulinoma was strongly suggested. Unfortunately, CT scan revealed no masses, normal pancreas, so he was referred for endoscopic ultrasound examination. Now we are scanning from the second part of the duodenum, and this is the pancreatic head, and we notice that there is an isoechoic well-defined mass in the region of the pancreatic head at the junction of the portal vein, splenic vein, and superior mesenteric veins. So it is at the venous confluence. So it is located in the pancreatic head neck region. And here this is a portal vein. And here this is the venous confluence. So it is located at the junction of the head and neck of the pancreas. It is well defined, highly suspicious of insulinoma, neuroendocrine tumor, according to the clinical and lab situation of the patient. Okay, we are now scanning from the stomach in the same patient, and here this is the well-defined isoechoic mass at the junction of the splenic vein, portal vein, and superior mesenteric vein. There is a clear line of cleavage between the mass and the venous confluence. This is a well-defined isoechoic mass, highly impressive of neuroendocrine tumor insulinoma, as the patient has frequent attacks of hypoglycemia. We decided to do AUS FNA to be sure that it is a neuroendocrine tumor, and doing immune staining for synaptophysin and chromogranin, because this patient will undergo a major surgery in the form of Whipple operation. So we want to be dead sure that it is a neuroendocrine tumor. Here we did FNA by 22G ecotip needle. Other option of this patient is to do EUS guided radiofrequency ablation instead of doing major surgery with significant morbidity and mortality. And sometimes the patient is poor surgical risk. So here, local ablation, EUS guided, may be a good option instead of doing major surgery. And sometimes the patient refuses to do major surgery for such small, mostly benign lesion. We are doing now fanning technique to take biopsy from many parts and many planes of the tumor, from here below and in the middle and in the high area. So we are doing now fanning technique in order to increase the yield of the FNA. Here we notice that there is a clear line of demarcation between the nodule and the venous confluence, so it is a resectable tumor, but unfortunately major operation must be done for this small, mostly benign lesion. Other alternative to avoid major surgery is to do EUS guided radiofrequency ablation.